So welcome everybody. We'll just give you a few minutes for everyone to come online before we make a start. Right. Oh, numbers are going up nicely. Maybe a few more minutes. When the numbers stop ticking over, then we'll do a little bit of housekeeping. Right. Right, so numbers are settling down. So kia ora everybody, welcome, good evening. My name's Jane Morphet. I'm the COVID Clinical Education Manager. And with me tonight, I'm pleased to have Nicola Metcalfe, one of the COVID immunisation education facilitators, and Catherine Tobin, another one of our COVID immunisation facilitators. So before we start, just a little bit of housekeeping. We've disabled the chat button, the chat function on this, but if you look at the bottom, if you scroll along the bottom, you'll see there's a Q&A button. So feel free to type in any questions you have for us as we go through. We'll be doing presentation in two sections. So Nicola's going to do a section on cold chain, and then I'll do a section on the vaccine administration and some of the changes. And you'll be the first people to see a new resource that's just been put on our website this afternoon. We'll have an opportunity for some questions after the cold chain. Then I'll do the bit on vaccine admin, and the rest of the evening will be spent answering questions. So hopefully plenty of time for everyone's questions to be answered. But depending on how many we've got and how many questions there are, if necessary, Catherine's also typing away in the background, responding to questions, so they may not all be answered live. And we are keeping a note of questions. So if there are any that we are not able to respond to this evening, we will be able to put resources up on the website and respond to them at a later stage. This webinar is also being recorded, as we always do, so people can watch it again at their convenience. Right, so I'm going to pass over then to Nicola, so you can share your screen and make a start, and Catherine and I will hide in the background. Right, that's looking good.
All right, so hopefully everyone can see that okay. So tēnā koutou, nau mai haere mai. Welcome everybody to today's presentation, and so glad that you could come and take some time out of your day to join us here. So just to remind you that the presenters cannot see or hear you during this webinar either. And as Jane said, please don't use the chat function, use the question and A function. So type in any questions onto there, and we'll support to get those answered for you. So today we're going to be talking about the storage, preparation and administration of the Comirnaty Pfizer vaccine used to help protect people in New Zealand against COVID-19. So what we're going to cover the Comirnaty's cold chain, so the storage and transport of the vaccine, how we're going to prepare it, some administration guidance, and of course opportunity for some questions. So why do we need to keep this vaccine so cold when all our other vaccines are stable at 2 to 8 degrees? So the mRNA molecules in this vaccine, they're actually quite unstable within human serum and plasma. So if they're injected alone without encapsulating that mRNA within a lipid nanoparticle, or you might have heard it being called a fat bubble, the body's own innate immune system will try and attack it, thinking it's a viral infection. And before the body's adaptive immune response has a chance to activate and use that mRNA in the vaccine as it's intended. So ultra cold storage, and that's the storage in the freezers, is used to prevent enzymes from naturally destroying that mRNA strand. So an analogy might be that you freeze your food that you buy from the supermarket to prevent it from spoiling, so you can use it at a later date. So that's sort of what happens with this vaccine. So companies like Pfizer, they're continuously doing some stress testing with the vaccine to determine if it's effective in different storage conditions. So things are changing all the time. You may have heard that there's work going on behind the scenes after MedSafe approved some storage between -15 to -20 degrees, which would allow unopened vials to be stored for 2 weeks. So in this case, the Ministry of Health and IMAC are doing work on the best way forward to help with vaccine storage and transport logistics in this case. So this slide here shows the different environments the Comirnaty vaccine is stored in before it's warmed to room temperature for dilution. So it's important that all cold chain processes throughout every step are adhered to and are documented and managed by knowledgeable staff to ensure everyone's receiving a viable COVID vaccine. So just a good point here to bring up that your local cold chain policy shouldn't be neglected. I know everyone's really, really busy, but make sure it is updated to show if you've purchased any new equipment, so fridges, chili bins, loggers, and that your new staff, because obviously we're getting a lot more new vaccinators coming into the fold, make sure that they're orientated to cold chain, they're added to your policy, and that you've got clear emergency vaccine storage plans. Staff that are new to these immunisation clinics should have cold chain policy reading time integrated into their orientation schedule. So the slide shows the ultra cold deep freezers. These are the ones in New Zealand, and then the Credo Cube, which is used to pack the Comirnaty vaccine into when they come out of those ultra cold freezers. With a logger, so the logger is, this is a red one, sometimes it's green, and then you've got your vaccine fridge and an example of a chili bin with a monitoring data logger system there. So this slide just goes over basically what I've just talked about, the different responsibilities of the cold chain in the process of delivering this vaccine. So our main people that are watching tonight, the main responsibilities lies here. So vaccine arrival at your provider, and then our storage and handling right up to the administration where the vaccine goes into somebody's deltoid. So this slide here actually comes from a new document entitled Guidance Supporting the Administration of the COVID-19 Vaccine, which Jane will go over a bit later in the presentation. So we've got an allowance here, you'll see, of 2 hours between +8 and +30 degrees Celsius for the vaccine. Excuse the little error, there's a little typo in there where it says vaccine instead of vaccine. That's going to be fixed. But that's just important for you to know about that, that cumulative 2 hour time that, that this vaccine can be out of range for. So vaccines, say you've got some vials of Comirnaty and they've gone above 8 degrees for 20 minutes, you've still got an hour and 40 minutes that you can up your sleeve that that vaccine can be stored at. So that is important to know, and it's documented here on this slide. Vials do take around 20 to 30 minutes to warm to room temperature, and if they're no longer cold to touch, then they're ready to use. And all vaccine movement times must be clearly logged. So times that the vaccine were taken out of the refrigerator, times any vaccines were returned to the refrigerator, and diluted vaccines are stored at room temperature or fridge, but need to be warmed before they're administered. The room temperature of your clinic room should also be monitored, and obviously we don't want clinic rooms going above 30 degrees. As we know, we're coming into winter time. Some of you will be delivering these vaccines to quite cold, perhaps rural sites, so don't let anyone get too overzealous with heating the room up before you arrive if you're going out of your normal clinic areas. So do document and record your room temperatures. So when things go wrong, so this is when a lot of people start to panic. So keep calm, and that'll help you take the correct action. Remember, your data logger is your best friend, and this will tell us information to make the right decisions on the vaccine viability. So if your refrigeration fails and your data logger readings confirm your vaccine has been exposed to temperature of +8 to +30 for more than 2 hours, you need to communicate to staff not to use the vaccines and label them. So that is really, really important. You don't want anyone going to use a vaccine that hasn't, that's not viable. If your fridge is still running, but is running between 2 and 8 degrees, you quarantine those vials, vaccines in your fridge. If your fridge is not within 2 to 8 degrees, you need to look for obvious causes of this. If someone's left the door open, you've had a power cut. But if you can't find any of those issues, then those vaccines need to be packed into a chilli bin that is between 2 and 8 degrees with a monitoring device, and perhaps need to be transported to a backup provider. So this is recommended that you document all your breaches and excursions, regardless of what vaccine it is, but specifically talking about COVID tonight. We need to document this in our cold chain management record and inform your immunisation coordinator of any excursions or breaches. And this particular document is available on the Ministry of Health website. We can put a link in the Q&A section if people are wanting that. You will also may have some other reporting documents that you need to fill out specific to where you're working as well. So this may not be the only document that you fill out in the case of a breach or an excursion. So in terms of the community cold chain excursions, who do you contact? So first of all, inform your clinical lead of your COVID clinic of any excursions immediately. So those initial actions of quarantining those vaccines, if needed, can be done and communicated to staff. And contact your local immunisation coordinator for further advice and actions. So this slide just documents who the regional immunisation advisors are for the different areas of New Zealand. And email is covered from 8:30 a.m. till 5 p.m, but to get a fast response, you may need to ring them. You can contact the clinical advice line, which is 0800 Immune, for guidance up till 8 p.m. weekdays or weekends. And we are here to help you. So please don't hesitate to ask for help. You're not alone. Phone numbers are available on the COVID-19 website as well, and the operations manual from the Ministry of Health. So I'm going to stop sharing my screen now, and we will come back and see if there's any questions.
Right, so there's no questions at the moment. So thank you for doing that, Nicola. Just want to clarify one thing. We've had a few questions, people wanting to know who to contact when they have cold chain problems. And as you set out really nicely, we're trying to make the COVID regional advisors as accessible as possible so you can get quick answers. If you ring 0800 Immune during sort of from 8:30 till 5 o'clock during the daytime, you're likely to be bounced back onto the COVID team. So that's why we're not recommending that. Outside those hours through till 8 o'clock at night and at weekends from 8 till 8, the COVID team cover the phone lines anyway. so you can jump straight in through 0800. So that's why there's a difference there. Normally the 0800 immune number doesn't deal with cold chain, and so most of the staff on there are not used to dealing with it. Right. Rather than putting up hands, can you type into the chat, please, so that we can respond to questions that way? Meantime, while we're waiting for people to pop questions in, I'll move on and do a few slides on vaccine preparation and vaccine administration. So let's just make sure we've got the right slides coming up. So I shall share the screen now. Oh, hang on, we've got one question, is it?
Yeah, we just have a question about the METOS system. So that is your logging system, but you still need to access it. So you go onto your online platform that you use if you've got METOS, and obviously it works very similar to the data logging system. So you can see all your readings, so you know what kind of information you need to relay to your immunisation coordinator.
So I think what the person's asking is, do they need both? So no, METOS.
Oh, sorry. Yes.
Data logger. So it's the all singing, all dancing data logger, if you like, that monitors all the time. So yeah, no, if you've got that, you don't need loggers, but you might need them if you were taking vaccines out into a chili bin and moving them to a different site or something like that. But for that fridge itself, if it's, as long as you've got two means of monitoring it. So you do need a second backup monitoring system as well. And the next thing I'm going to do is share where the document is around those things. So I shall do that right as we're speaking, because that's the first slide I come to on my presentation. So let's just make sure I've got my screen shared. So it's screen 2. And current slide. Now, can you just confirm that you can see that and not the notes page? Is that right? Thumbs up if that's working, Nicola. Yep, are we all right on that one? Everyone see what we're doing? So the culture.
I can see your notes page.
Well, I had a horrible feeling that was going to happen. That's why I'm having two screens. Bear with me. Stop the share. Let's just try that once more. Share screen, and so it's screen 1. I want so is that any better? Right, third time lucky. Let's close that down. That's probably why. Right. Is that working now? Okay, so this is our new fact sheet. Sorry, this is the vaccine preparation fact sheet. We've also got a new one that's stored in the same place on our website. So the new one is going to cover cold chain and also vaccine administration. So I've got a picture of it in just a couple of slides time. Just making sure I didn't put it in. Yeah, this one here. So this is our new fact sheet, guidance supporting the administration of the mRNA-CV vaccine. And then you've also got pictures here on the right-hand side around vaccine administration, drawing up doses, vaccine sites and such like, which I will cover in a little bit more detail now. So to find this, if you go to our COVID vaccination site, or if you're used to the immune.org site, click onto that one and you'll see immediately on there, you've got a link to the COVID site. From there, if you go under workforce, Facilitator, and then resources, and you'll find this is the new resource that's gone on there this afternoon. So it's got your names and of contacts on there, and that little chart that we had before that we were showing you on the cold chain rules and regulations. The next section goes on to the vaccine prep and such like. So this is a chart, the beginning of the flow chart that you should all be familiar with, that gets sent out with the vaccines. Now, as you'll know, we swapped the way we prepare vaccines a few weeks ago. Everyone should have been notified who had already done the training, and all vaccines that are going out should have these new instructions with them. However, it's really important that people follow the new guidance. So make sure you haven't got an old chart. We found a few sites where they've laminated these, put them up on the wall, and then didn't swap them over when the vaccine preparation changed. So why have we changed vaccine preparation? Well, there were two reasons. One, we had been having reports of a few bits of rubber particulates breaking off and going into the vials before the vaccines were actually drawn up and administered. And the thought was that the process of inverting the vials, tipping it upside down with a syringe and needle attached as we used to do, may have been causing the needle to move a little bit in the vial and dislodging little bits of rubber. The other concern was that we were mixing with a wider gauge needle, so a broader needle, that may also have been causing coring of the vial. Added to that, the more we followed international data and communicated with Pfizer, the more we found that all other areas are vaccinating with needles that are primed with vaccine. And this means that the patient receives exactly the 0.3 mils of vaccine. Whereas if you're vaccinating with a new needle on, you'll end up with a certain amount of vaccine left in the needle. Now, this doesn't happen when you're giving the normal stubby vaccinations that we're all used to giving in our 3 mil syringes, because there's space there for the air to rise to the top. And so as you give your vaccine, the last thing that's pushed in is a little bit of air that clears the syringe, through the syringe, through the needle, and you end up with what we call airlocking the vaccine into the muscle. But this doesn't work with the viscosity of the Pfizer vaccine using a 1 mil syringe. So we were concerned that we might not be giving full doses of vaccine to every patient if we continue to do it in the old way. There is an element of safety built in. Slightly under the dose is probably not going to cause a problem, but that's there for the inadvertent, maybe not drawing the dose up exactly accurately, not for us to regularly be using as a safety net. So the decision was taken based on those three things to swap our means of drawing up vaccines and administering them. So what we're doing now is we're using low dead space needles. So see how there's actually this space in here in a normal needle that was filled with vaccine, left filled with vaccine, is no longer being used. And these new low dead space needles mean that the syringe is squirting the vaccine straight through into that center part. So all of the vaccines being used. So those are the low dead space ones. Now, one of the concerns that people have raised is using this new technique, there's a need to resheath needles, and that goes against our best practice, which was one of the reasons why we didn't put it in the guidance to start with. Now, this little video on the left-hand side that I'm just going to show you here, I'm going to play, is a suggestion from one of the sites where they're using the foam that's sent out with the vials to hold the vials stable in transit. And what they've done is, as they were getting their vaccines ready, they've very carefully positioned the needle cap, poked it into the rubber, into the foam, I should say, not rubber. And then as you see, as they approach with their needle, they can just pop it in there, no risk of a sharps injury. And that hole can be used time and time again. And then at the end of the session, you can throw the box away when you get your next vials out and you can reuse it. So just a suggestion, there are other ways of doing it. Making sure that you're not touching anything. The other question that's cropped up is the number of doses per vial. If you're using low dead space needles, you will be getting more doses out of the vials. But what we're finding is that occasionally it's technically possible to get 7 doses. It's unusual. We're not expecting it to happen regularly. But if you do everything absolutely correctly, there is technically enough vaccine and enough diluent in there to actually be able to draw up 7 doses. So don't think it means that you've diluted things wrong, but we really strongly recommend that whoever is drawing up the diluent, a second independent person checks the amount you've put in there. And also each dose of vaccine that's drawn up by syringe is cross-checked carefully by somebody else independently as well. So one person draws up the diluent, and then somebody else will check it. And then once they've mixed it, added the diluent, the saline, to the vaccine, it's been inverted again 10 times. Then you draw it up into your individual dose syringes, making sure you're drawing up carefully and slowly so you don't get air bubbles in there, making sure you don't need to flick the vaccine vigorously. It's a very sensitive vaccine, so we need to try and be as careful with it as we can. So draw it up carefully. You'll see the numbers written on this vial here, and the suggestion is as you work your way around with each of your syringe and needle to draw up your 6 doses, you're going to be piercing the bung in a slightly different place, so we don't run the risk of just dislodging more rubber from the side of the vial by going in the same place. So we normally expect 6 doses, but if you get 7 doses and you were confident that you diluted it correctly and that was checked by a colleague, and you're confident that every dose of vaccine is exactly 0.3, then the vaccines can still be used. The other challenge we've come across is that a lot of people are not finding the vaccine site using our new recommended practice. So the new recommended practice is that you're feeling for the bony part where the top of the shoulder meets the top of the arm. That's the acromion process. Then you're feeling down the arm until you come to the end of the deltoid muscle. Now, this particular example has got quite a short deltoid muscle. You run your hand down to feel the edge of it. That's the deltoid tuberosity. You may find that with some people that would be a little bit lower, but you can feel that definition of the muscle. The injection site is midway between those 2 points, and that's usually along the axilla line. It'd be incredibly unusual for it to be any higher than that. Occasionally it's slightly lower. If you look at the vaccines that are being administered on television a lot of time internationally, you'll see that sometimes people are too high. And even in New Zealand, unfortunately, we have already had reports of people being vaccinated in a higher position where you're much more likely to damage the nerves. And we have had a report already of a patient who may have had nerve damage caused due to incorrect positioning of the vaccine. So it's really important that we're not vaccinating too high. So let's identify the landmarks correctly. This bit's taken from the handbook here. And the other thing is extremes of weight. We've been asked for guidance on extremes of weight. So here we've got somebody who's very, very thin. And obviously, if you're vaccinating somebody that's very thin, you may need to bunch the muscle up a little bit, holding it firmly between your hands, and then you can inject into the muscle so you're sure you're getting it into the muscle. The opposite extreme is those with larger arms. And so what you're doing is when you're assessing where the deltoid muscle is, you're also assessing the depth of tissue and muscle from where the bone would be. And you want to make sure that when you inject your needle using the standard 25mm needle, will it be deep enough to actually get into the muscle, or is it likely to just be sitting in the subcutaneous tissue, in which case you won't be getting such a good response. You may find that putting pressure on each side of the arm allows you to squish down the fat a little bit, if you like, and that may be all that's needed to allow you to get the needle to go right into the muscle. But with some people, you will need to use the 38mm length needles. Now, ideally, we would like the 38mm needles to be available in as narrow a gauge as possible. So ideally 23 to 25 gauge, but we are aware that at the moment there's a difficulty in getting hold of enough of these longer needles. So you may be using 21 to 22 gauge, which is also fine, and it's mentioned in the handbook. The only reason we would prefer the gauge to be narrower is simply because of the risk of coring the vaccine. When you put the needle in, there's an increased risk that you might dislodge rubber, but as long as you're checking your vials carefully to make sure that hasn't happened, it is perfectly safe to use the wider gauge needles. And the important thing is with our larger clients, we're making sure that we are actually getting into the muscle. If you're going to use a longer needle, it's essential that you draw up the vaccine using that needle. And not just swap a needle over for exactly the same reasons that I was just talking about. We want the needles primed with vaccine. And particularly in this case, because here, if we're vaccinating with the 38mm needles, a lot of those at the moment are not low dead space, if not all of them. And there will be quite a lot of vaccine wasted in the needle. So it's absolutely essential that the vaccine's drawn up using that needle. So in a big vaccination site where it's quite likely you're going to have several large clients coming in, it makes sense to draw up some longer length needles and have them available for your longer clients. As you go through, you could, so maybe out of if you have 5 or 6 vaccines sat at your workstation, maybe one of them should be a longer length needle, and then you can pick it up as you assess your consumer, I think is the term we're supposed to use, as they come and sit next to you. You can assess whether you need to pick that one up or not. If at the end of the session you find you've got long needles left, you can very easily draw the vaccine back into the syringe from the needle and then put a smaller gauge, smaller length needle on and squirt it back till you actually see the vaccine coming out the top of the needle, i.e. prime the needle that you're going to use to give the vaccine with. So that would be to save any waste at the end of the session if you did end up with extra doses left. What I do recommend though is that you have plenty of the longer needles available so that you're not putting the consumer at stress while you're waiting. Oh, I need a longer needle for your arm. I'll just go and get one, or I'll just draw it up in front of you. That obviously would be quite stressful and also might make them feel that you were doing something different just due to their size. So if it can be done discreetly, you just pick up the appropriate length of needle, give the vaccine, and then go and go back to whoever's preparing the vaccines and say, I've used that longer length one, can you get me another one? So I've got one available. Right, nearly finished now on my topics, and then we'll move on to questions. So vaccine errors. What do you do when something goes wrong? Love to say, well, it won't go wrong if you follow all the guidance correctly, but we're only human and realistically things will occasionally go wrong. So it's important that you're informing the consumer if something has happened. I would suggest that you consult with us first to get some advice without letting the consumer go away particularly. But for example, you've given half a dose of vaccine and the needle and syringe have become separated, some of the vaccines squirted out. The consumer may well be aware of what's happening, but you can say, well, hang on a minute, I just need to check what's the advice, what's the best way of dealing with this. And our recommendation would be that you give some more vaccine, so we're ensuring that they do have a full dose of vaccine. But take advice at the time, record the advice that you've been given, and then you can use that advice to reassure the consumer as well. Determining how and why something went wrong is really important because it helps us all to learn from it. So we really do like you to report lessons learned. So when you talk to us on the 0800 Immune line, we will ask you to share your learning with us. We'll send you a form, or you can use your in-house reporting form. That's then sent back to us. So we can look at whether there's things in the training that we could make clearer, whether there's information that would be better to have freely available for people, whether there's faults in the system. For example, we've had some people coming through that were under 16 years of age, and work's being done now to put alerts onto CIR so it flags if somebody's date of birth means they're under 16. Also in terms of information that we're putting out to people before they come to vaccination about questions that we want to ask them and things like that. So we have lots of ways of feeding back into the system. So it's really important that we know if things have gone wrong, or even if things nearly went wrong, that's equally important. If the error happened while you're in the vaccination process and a patient was involved, then you can record that under adverse events error on the CIR. And if a patient's involved, then CALM do like to be informed as well. We're happy to share any reports that come through to us with CALM as well. And both CALM and IMAC will treat them in confidence. We won't be publishing their details to anybody else. We will just be taking the nuances of what's gone on and how we can learn from that and how we can improve and help other people prevent them from making the mistake. Right, that leads us on to the question time. So I'll come off shared screen and then I'm happy to take questions.
So Jane, I might forward this towards you. Can a person who has passed the COVID and CI or online course draw up the Comirnaty vaccine? Do they need to be a clinical person?
Okay, so at the moment, it's only clinical people that are doing the vaccine COVID course. And we would normally expect them to be provisional vaccinators as well as doing the COVID course to be able to give COVID vaccines. What we are saying is that in certain cases, registered nurses, for example, or pharmacists who are just going to be involved in drawing up the vaccine could just do the COVID module. And there is also at some sites, we're looking at the role of pharmacy technicians, because obviously they're super trained in drawing up and dealing with medicines and such like, but they would never work on their own. They would always be working with a vaccinator or a suitably trained pharmacist or registered nurse. So at the moment, that's where the rules stand. The only exception, as I say, is the pharmacy technicians, and they would be working alongside somebody else. We do recommend 2 checkers, and both of those checkers should be either pharmacists, registered nurses who have done the COVID training, or fully authorised vaccinators, ideally. Makes sense for people to do both the provisional course and the COVID course. Then they can move around the sites. They're more useful at the vaccination centre than if they're just drawing up vaccines.
There's another question, Jane, about the thermostability data on the vaccine. Where might it help affect that information?
Say that again, the thermostability data?
Yes, correct. Where would be the official documentation on that information?
The official documentation on that, we've got the information that we're sharing is the information that's in the data sheet that's available on the fact sheet that I gave you. It's also in the data sheet. And so that's freely available for everybody. If anything is outside those ranges, we ask that you contact us and we will discuss it with Pfizer Medical. We do have some in-house stability data that's available to us, but we're not allowed to share it more widely. And it would be used on a case-by-case basis. Will depend on things like whether the vaccine's been defrosted before or not. Sometimes vaccines can be defrosted more than once. So there's all sorts of different things that play a part. So that information is not freely available. It's available freely via the 0800 COVID team. So contact us and talk about any specific situations that are outside the normal data range.
There's a couple of questions about the low dead space needles and larger people. So one practice at their clinic, they draw up the last dose with a larger needle so that they have one longer needle in each tray. And I suppose it's just the availability of longer needles. Will they be low dead space needles or regular needles?
Yeah. So 2 things on that. One, that sounds like a good idea. 1 out of the 5 doses is longer. And as I say, you can always swap it later if needs be. You will have enough vaccine to enable you to do that if you draw it back into the vial. The low dead space needles are proving a problem in the longer lengths. So the ministry do have some on order, but they're unlikely to get them till August or September is my understanding. So until then, they are relying on normal longer length needles being used.
Okay. Someone know, would the Medicines Act cover the drawing up process?
So what was that about the Medicines Act?
Would it cover up process? So I'm presuming I'm not really sure what the angle is there, but if they have done the core or not.
Our recommendation is that people who are drawing up vaccine do the COVID training so that they have a fuller understanding of how the vaccine works and the importance of the storage and such like. Whether that's a legal requirement, I think is more debatable, but it's a very common sense requirement and it's currently in the operations guidelines. I know that they are looking at this from a legal point of view as to whether it would be feasible for COVID specifically trained people to be able to draw up vaccines, and theoretically a pharmacist scope or a nurse's scope would include that. So I can see where you're coming from, but our recommendation is it doesn't take long to go through the COVID course. We'd prefer it if people did that. That's our recommendation, and my understanding is the ministry is supporting that at the moment, although I am aware that there is some ongoing discussion about that.
A question on warming the vaccine. Can it rubbing it between your palms, is that okay to warm it, or do you just have to leave it sat at room temperature?
You could hold it in your palms. I don't particularly want it being moved any more than the gentle inversions. Not that it's a major issue. You can hold it in your hands, but I think we've all got more important things to be getting on with than holding a vaccine in our hands, unless we're really, you know, one last patient and we need to get this done because we all want to get home, in which case we're keen to get it warmed up as quickly as possible. Generally, I would just say leave it on the table. It shouldn't feel cold to touch. And that's when you know that it's sort of reached room temperature, when there isn't a difference of temperature when you're holding it.
Okay.
Bleeding
disorders.
Yeah, warfarin.
Yep, warfarin, yeah.
Okay, bleeding disorders and warfarin. What I would direct people to is also our vaccination guidance. That's the other important fact sheet that we've designed that's intended to be there for vaccinators to have in front of them when they're vaccinating. So it lists the screening questions, and then it gives you guidance as to what you do if the patient is on warfarin or has is on blood clotting, has other blood clotting problems. In there, it's very clear that warfarin isn't a problem. What you would do is check whether they, I mean, ideally their INRs are in normal range for them, but you can still vaccinate. What you get them to do is hold firm pressure after you've vaccinated. Vaccinate IM. We don't use subcutaneous with the Pfizer vaccine. Vaccinate, hold pressure on firmly, and then make sure you put a pressure dressing on there. So you've got a cotton wool ball, maybe a couple of cotton wool balls and some tape held really tightly across there. And then when you take them through to the observation area, make sure that whoever's in the observation area keeps a check on that on a couple of occasions. And after about 10 minutes, the pressure's released to make sure that you have actually stopped the bleeding. Sometimes you may need to keep the pressure on for a little bit longer. If you've got a patient on with more serious clotting problems, then you may want to seek specialist advice first. But there's a list of all the accepted medications, blood thinning medications that are fine to proceed with vaccination with, listed on that fact sheet, which also is on resources in the same place that I mentioned our new one's gone on to. So we've talked about the document on the excursions and where you can find that. So that's on our website under workforce, and then vaccinator and resources.
Can the CIR wait time be changed to 30 minutes by the vaccinator if the consumer needs to stay longer? It's a good question. I'm not entirely sure if you can manually change the time. I know
that they are well aware that patients may need to stay longer.
Yeah. So it would be a matter of, I know in some clinics I've been going to, the vaccinating nurse has been verbally informing the recovery nurse that a particular patient needs to stay the full 30 minutes if they've had a previous concern with any medications or vaccinations prior.
There is a place on the CIR where you can edit and add in additional information. So that could be an area where you can add a requested patient to ask to remain for another 10 minutes and observed.
There was a question I saw that's actually gone now, but was on screen asking about if you put an adverse event into CIR, will it automatically go through to CALM? And yes, it does. So any event that happens during the vaccination process, so the first 20, 30 minutes, that gets recorded onto the CIR as an adverse event. CALM gets notified about that. Anything that happens after the patient leaves the vaccination site would be reported to CALM via their online CALM COVID reporting form. And just a message there from CALM, I've been asked to please remind people when you're filling in the online form, please, please, please tick the boxes. Don't just put free text in. By all means, put free text in, but the boxes are there to allow them to automatically screen for important events. So that's why there's a box to tick for serious event or breathing problems or whatever. So quickly tick any of those boxes that apply. And then if it is a serious event particularly, they'll pick up on it almost immediately. Whereas otherwise it may take them just as they're routinely going through if it's just put in on free text. So especially if it's important, tick those boxes. Right. Am I saying that it doesn't have to be a vaccinator to draw up? I'm saying there should be 2 people that are drawing up. They do need to be pharmacist, registered nurse, and ideally we'd like them to have done the COVID course, but some sites are not insisting that they are also provisional vaccinators. So they don't technically have to be a vaccinator. They do need to be a nurse or a pharmacist that's done the COVID course. And ideally we'd like them to do the provisional course as well. The second checker on some sites is a suitably qualified pharmacy technician who has also done the COVID course and has had extra training. Wow, no other questions, and it's 1:45. We'll just give people a couple more minutes. Hopefully we covered everything as I went through the presentation, so I'm hoping that's why there's not too many questions. Be a little bit worrying if there were too many questions on how do I actually give the vaccine at this stage of the rollout. Right, can I give you an update on APHIS? You'd have to look on MedSafe. They're giving, I think it's a weekly update now on the adverse.
Yeah, there is a weekly update on the MedSafe website.
Can another person dilute and then the vaccinators administer? This is why we want to have 2 suitably qualified people checking and drawing up vaccines, because that needs to be recorded in the site records, who they are and who's taking responsibility for this. And then also within your vaccination site, it needs to be clearly recorded that the expectation of the vaccinator is that they are giving a vaccine that has been drawn up by somebody else who has followed that guidance. So yes, as a vaccinator, you can give a prepared vaccine, but you have to be confident yourself that the process has been followed appropriately. So that's why we want you to be reassured that there's 2 people checking and that they are suitably trained and suitably qualified. It's important. But provided that's being done and it's being recorded and it's clear that the expectation of your employer and the site that you're working at is that you will vaccinate using pre-drawn vaccines, then yes, that is how internationally all the mass vaccine sites are working. It would be unusual for a vaccinator to draw up their own vaccines and then give them in the big sites. It seems to be, it's more of a production line, if you like, and it's more effective to have one person. It may be you taking it in turns to do it, but certainly that is what most areas are doing. There is the other option, if somebody's not confident in doing that, doesn't feel happy, perhaps they'd like to take on the role of preparing the vaccines for other people that are happy to work under those circumstances. Right, may not be relevant, but I'm previously a vaccinator, midwife, and volunteered in Waikato. Oh, okay, so anybody that wants to get COVID vaccine training, you can access it free online now. So you just need to go onto our training website, the LMS website. You can access that through the immune.org website under training. And you can just go onto the COVID course, provided you can tick the boxes that say that you are already authorised, or you are provisionally authorised, or have completed your provisional authorisation training, even if you haven't done your peer assessment yet, then you can automatically go onto the COVID course now. That wasn't the case up until about a week or so ago, but we're making it as freely available to everyone as possible. Part of our rationale for not having it freely available to start with is that we anticipated there would be a few hiccups in advice, like the drawing up advice changing as we work with the vaccines and work out what's working best. So we are confident now that what we've got on there is the latest information. It is still possible that things might change. So do sign up for our newsletters as well. But please sign up and get yourselves trained as COVID vaccinators. So we've answered that one. Right, patients with, there's a specific question here about a patient with blood clots. One of the lovely things about the Comirnaty vaccine is that it is so safe to be used in patients that are immune suppressed, in patients that have had blood clots, in patients that are on cancer therapies. There really is only contraindication to giving this vaccine is if somebody has had a previous anaphylaxis to the vaccine or something that's in the vaccine or is acutely unwell. So this vaccine has not been associated with blood clots like the AstraZeneca vaccine. And certainly, you know, vaccinators, patients that are being vaccinated can seek individual advice from the vaccinator. And if you're ever in doubt, feel free to ring us on 0800. We have a direct line to medical advisors, so we can double check information for you at any time if something odd and unusual comes up. But basically, it's a really safe vaccine. It has a good safety profile. So there's very few patients that can't have it, which makes life a lot easier when we're vaccinating. It means we're not having to leave people out. So will provisional vaccinators, registered nurses be required for the rollout? Most definitely. Anybody that's looking for work at the moment or extra hours, please list yourself with the surge workforce, or just contact your local DHBs. They'll be biting your hand off when we roll into the large scale rollout in a month or so's time. So you want a link for the COVID training? Yeah, can one of you look it up for me on the link to the LMS website so we can put it on while I'm answering questions?
Yep, sure, I can do that.
Do we need vaccinators for the Cook Islands? Oh, that's very thoughtful of you. We've actually got a team of staff flying out tomorrow to the Cook Islands to help with vaccinating. I believe there's some ministry staff going out as well. My understanding is we're just supporting the staff, the people in the Cook Islands anyway. We're just getting them up and running with it. So I don't think there's a demand for any more at the moment, but if there was, it would go up on our website. So once you've completed the online course, if you are already an authorised vaccinator or a provisionally authorised vaccinator and you've completed the COVID course, you'll need, a part of that is the access to CIR as well, then you're ready to contact the local DHB or go on the surge workforce as a fully trained COVID vaccinator. If you mean you've completed the provisional vaccinator course, there's then an extra step that you need to be assessed as a vaccinator. And once that's done, you send all the paperwork through to us, including your CPR certificate and your APC. And we will issue you with your provisional authorization. Once you've got that and the COVID certificate for doing the course, then you're ready to run. It is possible to use alternative sites to the deltoid. I think we've had a question here saying if somebody's had bilateral mastectomies and lymph node removal. We have had a couple of situations where we'd give specific advice and you could use the deltoid muscle. You'd need to make sure you've got a long enough needle to access the deltoid, sorry. You could use the thigh muscle, vastus lateralis, but you do need to make sure your vaccination needle is long enough that you're getting into the muscle. Patients that are pregnant, we're going to do a webinar on pregnancy and COVID vaccine related questions, but it is safe in pregnancy. All the research that's coming in so far is showing that it's safe in pregnancy. It's just at the moment there isn't as much data as we would normally have before we recommend a vaccine in pregnancy, and since there isn't a risk, we're saying that actually it's probably better for people who are pregnant to wait. There is absolutely no reason to be concerned about fertility or to be concerned should somebody fall pregnant after they've had the COVID vaccine. So we've got no concerns on that. It's just an extra cautious approach unless somebody is a healthcare worker who may be exposed to COVID or working in managed isolation type facilities and they're pregnant. Those people we would definitely recommend are vaccinated, but for the rest at the moment we've got a cautious approach that is, let's just wait till we get a little bit more data from some of the studies that are taking place abroad with pregnancy and see what the outcome is from those. But the interim results are looking really good. We're anticipating that in the not too distant future we will be recommending it for all people over the age of 16, and that age limit is likely to drop as well. Ethnicity data is recorded, it's linked to the NHI number. Okay, so we've done that one. Is there
any online training to update CPR? Yeah,
look, I'm sorry folks, I did promise you CPR training. It is actually in draft form at the moment. As a project that we are working on. The non-regulated workforce has taken priority temporarily, so there will be a couple of weeks delay before we get the CPR training up on our website. It will be only available in certain areas, but we are looking to have a module that will top up people can use as a top up for administration of adrenaline. So if you've done all the other bits that are required as a vaccinator, there will be a module that you can do about IV administration. One thing I would say though is, some of you may not have noticed, but in the recent update that came out, the May vaccine update, right at the bottom, there's a link to the ministry website where there's new regulations around authorised vaccinators and CPR certificates, and they are extending all CPR certificates for up to a year. They do want you booked on courses, but if your certificate has expired and you're not able to get booked on a course, then you've got extra leeway. So there's a document about that there as well. Right, how are we doing? I think it looks like we've got to the end of them again. Right. Some occupational health nurses not employed by DHBs are not able to book into a programme. Do you mean a CPR programme? We are conscious that there is a demand for CPR and have to fully complete course themselves. I'm not sure what you mean, Anne Marie, if you, yeah. Catherine, okay. Okay, do these webinars go towards, no, they don't, I'm afraid. These are just extra education. You should be able to print off a certificate at the end of it, which would go towards your professional development, provided you write a reflection on it. So, you know, these were the key messages I had, and this is how it's going to affect my practice, something like that. Then you can add it to your portfolio. But no, it's not part of your COVID vaccine training. Not able to book in for a COVID vaccine. Okay. There are booking numbers for booking COVID vaccines for healthcare workers in most regions. If you ring through to 0800 in the morning, we'll be able to give you the numbers for most areas. There's a couple of areas we're still looking for the booking numbers for, but hopefully we'll be able to help you. If someone presents with a temperature of more than 38, or if they're acutely unwell, we'll postpone the vaccine, just as we would normally do. So I think I said that the only contraindication to vaccine, a permanent contraindication, is allergy. But obviously there's a temporary precaution if somebody's acutely unwell, especially as we know this vaccine can cause temperatures. So let's have them feeling reasonably well. But a cough or a cold or something like that is not a reason to postpone. So does the vaccinator have to have the full COVID vaccination course? There's no reason why having the full vaccination course, you're not going to catch COVID from the vaccine. So it's no different from working in any other healthcare environment. We've got a lot of people around. The likelihood of having community spread of COVID is low. We are encouraged to have the vaccine. People are bound to ask, have you had it? It boosts its credibility. We are healthcare workers, so we do have a slightly increased chance of coming in contact with it, but it would be up to the local DHB that you're working in to say, and my understanding is they're not insisting on it. The vaccination is a voluntary thing in New Zealand. The only sites that they are insisting on is managed isolation, because obviously the risk factors do have to play a part there. No. IMAC CPR does not require the IMAC does not require, so it's not IMAC anyway, it's the immunisation handbook. The Ministry of Health have the handbook, and IMAC provides guidance to it. The updated guidance is that you need to do a CPR course that covers certain things. Does not have to be a Resus Council approved course. It needs to cover, and the key things are CPR for all ages, use of bag valve mask, 2-person or 1-person, use of an advisory defibrillator, treatment of choking. So most basic courses will cover those things anyway. The use of the bag valve mask is a little bit more extensive, and we do like the course to cover emergency management of anaphylaxis and the use of adrenaline. But it doesn't have to be core immediate resuscitation council standard. That was old handbook. It's been updated since then. For most people working in GP practice, or even if you're at the mass vaccine sites, it would make sense for you to do a training course to that level, because you may well come across other people with medical emergencies. Far more likely you come across those than ever you do people suffering from anaphylaxis. So we set the basic standards are set in the handbook. It doesn't mean you can't do more. We're not saying we don't want people doing that course. That'd be fantastic, but it is not a requirement for a vaccinator. Right, and we're coming to 6 o'clock exactly, so I think we'll call it a night. Hopefully that's been useful to people. It will be recorded, and I wish you all well in your vaccination endeavours, and it's great to see there's so much interest, especially at this time of night, so thank you for the wonderful work you're all doing. Say good night then.
Mihi nui kia koe, everybody. Yes, thank you very much. Oh, we're getting more questions.
Thank you, which is always nice. It's always nice to end with a couple of thank yous coming in, which is great. So regularly getting 7 doses. We check the syringes and diluent. I'm interested to say it's unusual. That's just Pfizer recommendations. They're saying they don't want people to assume they'll get 7 doses out of it. If you are extremely careful and you are managing and checking, cross-checking everything, it is certainly possible. So well done you, you're getting an extra dose out, but I wouldn't want people to worry that they're not. Right, I'm going to call it a day then. So good night, everybody.
Night.
Yeah, good night.